the role of PDC is not limited to clinics, but it does go beyond it. And keeping that thought in mind, Team Byonyks and me have designed this session for today. And I'm really excited to introduce you all with our guest today. That is Nurse Joanna, who has been in the field for last 38 years. And she is currently working as the Senior Quality Control Director in the Satellite Healthcare USA. And she is the author, co-author, and reviewer for many nursing curricula, and she is the ISPD member for Nursing Liaison Committee, and she is also the nursing representative of ISPD North America Chapter Council. She is the recipient of 2024 Barbara Provant Lifetime Achievement Award in Nephrology Nursing as well. So, Nursing Joanna, it's really a privilege to have you here and do for this session. We are really looking forward to learn a lot from you. And without any further ado, I would like to hand over the session. So please enlighten us.
Thank you so much for the very generous introduction, Dr. Rashina. And good morning and good evening to all. And with that introduction, I'm going to start sharing my screen and my presentation. Okay, let me do the technical check. I want to make sure you're seeing the slides as helping PD patients in full screen. Can you see it?
Yeah, we can see it.
Okay, great. Thank you so much. And again, thank you for the introduction and thank you so much for the opportunities. I'm really passionate about training nurses, training patients, and in my heart, I'm an educator. And I feel like only with knowledge that the nurses can be empowered to provide the best care to the patients. And this will be an interactive section, so please feel free to ask any question at any time. Right now, I don't have visibility of the Zoom meeting. I'm only looking at my slide. So I would like to ask you to either speak up, unmute yourself if you want to, or put it in the chat, and we'll be monitoring the chat and read off the questions. Okay, so like I mentioned, this is an interactive section, and this I want to provide very practical nurse-centered focus on managing patients' non-infectious complications when they are on peritoneal dialysis, because we know that these patients are trained to do dialysis at home. During the training, not all the possible complications, issue, problem will arise. So we can only teach them so much. And we can teach them, like hypothetically, if this happened, this is what you do. But fortunately, they have an access to the on-call nurses, the on-call clinicians when something happened and they can call. But keep in mind, when they make that phone call, they usually are very anxious, very worried, because naturally people a lot of time think about the worst, right? So how can we as a clinician help to calm the patient down, guide them through the process to troubleshoot with them over the phone? So we want to improve the patient experience, enhance technique survival, and then reduce any avoidable emergency room visit. I don't know about Pakistan system, but in the United States, if a patient go to the emergency room, a lot of time they ending up waiting for many, many hours, and they can potentially expose to other infectious disease, some cough, flu, okay, in the waiting room. And in the emergency room, we might not find equipped, well-trained PD nurses to really help to triage the problem effectively and efficiently. So the best person to help the patient will be us, the PD nurses. Okay, this is the objective of the presentation today. and you can read it, okay? So, a brief introduction. As a PD clinician, you already know peritoneal dialysis is one of treatment options for a patient with ESKD. And then they usually perform the treatment at their residence, and they have to go through training. And in the United States, the training usually range from 7 to 15 days. But from my experience, even though you have some patients that are very smart, they learn the skill in 2, 3 sessions. You might want to keep them a little bit longer just to make sure they get that process ingrained in the memory and not to take shortcuts. And on the contrary, sometimes we have some elderly patients or patients that don't learn the technique successfully within that 2 weeks time. We will have to extend. Then we need to cater their learning style to teach them so that they can be successful at home. And I'm going to share with you one of my own experience. I was training this elderly couples. Okay, being elderly and being forgetful, they remember one step one day and then the second step the next day, but then on the third day they forgot about the first step. So how we did it is we really want to imitate how they do the dialysis at home. We at that time we didn't have the mechanism or the process to do home visit training. So we asked the patient to come to the clinic like 3 times a day. So it simulate that what they will do at home in the morning, this is what they are going to do, and then they will go about, and after they disconnect, they will go about and do what they have to do during their regular daily life. And then when the times come, they come back and do it again. We did the training for, I would say, about 6 weeks. But fortunately, they were successful at home because of this a little bit modification in the training technique and process to cater to the patient's need. And then another thing I want to talk about is also about training patients. Not everybody learn the same way. We need to be able to assess the patient learning style. There are some formal process, but then as an experienced trainer, you can also spot, you see how the patient learn better by listening, by watching, by doing, or combination. The worst thing that we can do is to train all the patient using only one method, thinking they will learn it. And you say, this is my standardized training curriculum, I'm going to follow it. No. And sometimes we have to take that opportunity. If something happened, a contamination happen, a complication of not draining happen, that's the time we utilize that teaching moment to teach them. Hey, you see, this is happening. And if this happened, this is what you do. It helps them to memorize it. And then another thing is we all have some training material, maybe handout for the patient. Okay, follow the steps. Is that going to work for everybody? Maybe not. Sometimes I ask the patient, I want you to write it down in your own words, because when they write it down in their own words, usually they can understand it much better. So this will help to have successful PD training. And then when they learn the technique, when they learn the process better, it will really help troubleshooting down the road. And then in terms of troubleshooting, another trick is make sure we can share the common terminology. I have patient call me on the phone, excuse me. I have patient call me on the phone and say, "Hey Joanna, the thing is not working. That thing is not turning. That thing is not feeling." I say, "Calm down. Wait a second. Let's talk about what thing you're talking about." So we don't have to push medical terminology. Oh, the dialysis solution, the fill line, the drain bag. find something that is easy for them to assimilate so that you can have a common ground. So when they tell you what they are referring to, we can understand that. Okay. And like I mentioned earlier, most non-infectious PD complication will show up as a very worried call or a message. Something doesn't feel right. I have a problem. The thing is not working. And for the PD nurses as frontline responder, what can we do? What can we say to help the patient to get through this trouble or issue so that they don't have to go to emergency room? Okay, I'm going to pause here. Any questions so far? Okay, thank
Yes,
you.
Joanna. I want to ask that if the patient is from out of city and he come for dialysis, then how you manage his training at? Do you ask them to stay at hospital with you, or you just send the PD caregiver to their place?
You know, it's breaking up a little bit. Can you repeat it one more time, please?
Sure. I want to ask if the patient is from out of city, then how you manage their training? Do you ask them to stay with you, or you send your PD caregiver to their home?
Okay, it really depends on the system, okay, and the nurse's schedule. If you have capability to train the patients at their place of residence, the place that they're going to perform dialysis, that will be very ideal. They don't have to change the way they think how the dialysis procedure should happen when they go back home to apply what they learned at the clinic and then modify that into the home environment. So training at home, if you can do it, that will be great. But then also there are times that, you know, the nurse have to take care of the existing patient, training new patient. We might not have capability, the time availability to do that, then the patient will have to come. So then being flexible. If you say, well, our training schedule is 2 to 3 hour section, maybe just to be more convenient for the patient, we extend it to the longer time. Okay, give breaks in between so they have more practices. And then instead of training for 7, 15 days, maybe we can train the patient in 5 days. That decrease the way the need for them to travel and shorten the time, but the number of hours of training is still the same. Okay, thank you for the
All right.
question.
Thank you.
Okay, so I want to give you all a pat on the back and kudos to you choosing PD nurse as a career because it is an excellent way to take care of patients. Why do I say that? Over time, you will find yourself almost practicing like an advanced practice nurse because you know the patient, you know the therapy, and patient comes to you, you have direct contact, and you build up that relationship, trusting relationship. And on top of that, you learn the communication skill. We call it the S bar. Okay. And you teach that you will be able to do a very good collection of data from the patient and then transcribe it or ask the appropriate question, transcribe it and relate that message to the physician. And then clearly, without any second guessing, being judgmental, and then so that the physician can help to prescribe the treatment needed to help the patient. So in the end, you will get an excellent trusting relationship between the nephrologist and the patients. Okay, I hope this will empower you to stay on as a PD nurse for many years. And taking care of chronic patient is very different than taking care of patient in the acute hospital. You just like each patient is almost like a case for you. But taking care of chronic patient is a family. is somebody that you can relate to and care for. When they walk into the room, you just look at the face. You can spot they are happy. Oh, something's wrong. You look at their ankles. You say, oh, you have some edema since last I saw you. What's going on? That is very important. Okay, so these are some of the non-infectious complications I'm going to talk to you about today, and I'll go through it one by one. So inflow and outflow pain, I'm talking about the non-infectious one, is very common and is very depressing, distressing. Who likes to experience pain, right? And then a lot of time they might experience it initially when they first come to us with that catheter flush, or sometime even right after the surgery. Some patients say, I don't know why, after the surgery, I have pain in my rectum. Or some male, they might say, I have some pain in my penis. That is very scary for them. How can we reassure them? We cannot say this is completely normal, but it's not uncommon, first of all. And a lot of time is caused by a catheter sitting on a sensitive spot, and there's no fluid because we haven't started dialysis yet. No fluid, no cushion. No cushion to float that catheter that is sitting right on the organ, the intestine, or very sensitive area. Okay, so all we can say is make sure they are not constipated. Okay, I'm going to say this. The standard bowel is in constant competition or fighting a war or battle with our PD catheter. They are not our friend. So make sure the patient is not constipated. And you'll be surprised, even with gas, the standard bowel with gas can exaggerate that discomfort. So we need to make sure the patient is not constipated, doesn't eat a lot of food that produce a lot of gas, and then reassure them, okay, sometimes this is what we call dry pain because there's no fluid floating and being a cushion for you. But when you start dialysis, it should be better. But for right now, that make sure you're not constipated, and then we want you to take some pain medicine. Now, taking pain medicine is tricky. If they are taking some opioid containing medication, what can that cause? Constipation. So we have to make sure there is a balance. And if they can just get by with some over-the-counter like acetaminophen or ibuprofen, yeah, controversial because it's not for kidney function. If they can get by with some acetaminophen, we'll do that. So, okay, if the pain happens after the patient has started dialysis, so you get a call in the middle of the day, either during work hour or off hour. The patient say, I have pain. I have abdominal pain. The first thing we need to do, is it peritonitis? Why is that important? We all know peritonitis, this infectious complication, can have tremendous consequences. The patient, if we don't treat it immediately, we don't provide timely treatment, the patient might have to come off the therapy. So then we need to ask, okay, have you done any exchange just recently? When was it? Is the effluent, the drain fluid, clear or not? If it is not clear, we need to think about peritonitis, activate that peritonitis treatment process immediately. Okay, if the patient say, no, I just did my exchange, or I did my exchange an hour ago, is clear. But if they say, my exchange is, I get off my machine in the morning, right now is 5 p.m., so I haven't done any exchange. Ask them to do an exchange to actually visualize the clarity of the drain fluid. So again, we're trying to rule out peritonitis. Okay, if they say we get the conclusion, the fluid is clear. Now, then we have to ask them the timing of the pain. And I'll show you in the next slide why is that important. We want to be able to ask them, is it at the beginning of the inflow? Is it during the inflow and lasts for hours? Is it when you're done with the fill? Or is it towards the end of the outflow and goes away shortly after the inflow? Or is it at all time? And where is the pain? Is it localized or is it throughout the whole abdomen? Again, we need to ask the patient recent bowel movement. Another important point, no matter when the patient calls us, we need to be able to use our calm demeanor. As a nurse yourself, even though you might be thinking the worst scenario, oh my God, the patient is having peritonitis, don't do that. You need to show them you are in control of your emotion and you know exactly what to do to help them get through this discomfort or any complications. Okay, when you are calm, the patient will be calm. If you start to talk about really fast and say, wait a minute, what's going on? When did that happen? They are going to get nervous and they're going to think about, did I do anything wrong? And we need to tell them, don't worry, let me ask you some question. If they start bubbling, you slow down and say, okay, yes, don't worry. Now, help me out here. Help me out here. Solicit their help. I have some questions to ask you, and this will really help me to help take care of you. So let's do this. But in a way, you don't want to just stop them. Hey, stop, hold on. Don't do that. Nobody likes to hear that because they want to be heard. You let them talk the way they want and find the moment when they pause a little bit and say, okay, Joanna, I hear you. I'm here to help you. Let's see what's going on. Okay, can I ask you some questions? Okay, I think you can feel it now, right? I don't see any participant. I hope you are nodding your head. Okay, so the assessment. Why do we do the assessment? The clarity of the effluent. If it is cloudy, we need to rule out peritonitis. Not 100% cloudy effluent means peritonitis, but anytime the patient have cloudy effluent, we need to think about treating the patient as if the patient has peritonitis. We don't want to put ourselves in denial. Sometimes we do. Oh, the patient doesn't have peritonitis, not. Maybe it's something else. Maybe it's fibrin. No, we need to heighten our alertness to think about peritonitis and initiate the treatment extremely timely so that we can save the membrane, okay, and prevent further complication like sepsis. All right. What if the pain is at the beginning of the inflow only? A lot of time it can be the flow is too fast. We call it the jet effect. Okay. So what can we do? Slow down the flow rate. If the patient catheter has a regulator, slow it down. If the patient is doing a manual exchange and there is no regulator, lower the back position so that the gravitational flow is not that strong. It might be the dialysate is being too hot or too cold, or the patient is having constipation, or even gas in the stomach. If they say, oh, I've been passing a lot of gas, then we need to think about that. How can we avoid it? Decrease the gas producing food. Okay. They might know. If not, is working with the dietitian, it can be trial and error. So we need to teach the patient to check the temperature of the dialysate before they do the dialysis. And when I train the patient, I use that as an analogy. Okay, think about this. If you're drinking a glass of hot water, as soon as it touched the mouth, your oral mucosa, your tongue, you say, "Oh my God, it's hot." Your instinct is spit it out. But for our peritoneum, we don't have that. We cannot handle it that quickly. Spit it out. So if it is too hot, by the time the patient feel the discomfort or even pain, we might have already scalded the membrane. So definitely we don't want it to be too hot. And I know some institutions say, let's measure the temperature of the dialysate using one of those infrared heat gun. That's great. But what if we don't have it? Some institutions say, oh, put a thermometer, wrap the fluid and check the temperature. Yeah, sometimes it give you a temperature, sometimes it doesn't. But simply, how do we feed our babies? Make sure the water, the milk is not too hot. We use the back of our hand. We feel the temperature. If you think with your hand you feel that it's too hot, then it's definitely too hot. Don't use that solution. Okay. So when it is too cold, sometimes people will have the chills. Okay. So they can interpret that as a painful situation. But at least cold dialysate is not going to harm the patient. So if that's the pain that they feel, and after you rule out all these things, you might need to call the doctor and see what the doctor prescription will be or diagnosis can be. Okay. When they said, I only have pain after I'm done with the fill or halfway through the fill. For the commercially prepared dialysis solution, the pH level is lower. With the low pH, patient can actually feel some pain. Okay, so what can we do? Some physician will try to add sodium bicarbonate, but keep in mind, adding sodium bicarbonate to the PD fluid can neutralize the PD fluid, but also is a break into the sterile system. That means we can put the patient at risk of peritonitis. And also, we cannot just do it at one exchange. This has to be done on an ongoing basis. And then also, the pain can be due to the high intra-abdominal pressure as a result of the fluid we infuse into the peritoneum, especially for newer patients. Okay, so that might go away after a while. And I would like to share with you something that I do and I don't do. When I start a new patient with the full fill, usually is 2000 cc 2 liter. I don't ask them, do you feel full? Because as soon as you ask the question, they're going to bring the mindset and get that attention to the abdomen. Do I feel full? Oh, yeah, I do. Now, having to do PD is a treatment for their ESKD condition. It's something that they have to do to sustain their life. And we know it will provide them with good quality of life. So what we have to do is to help them accept this higher abdominal pressure discomfort instead of amplifying and give them a lot of sympathy, not empathy, sympathy, and say, "Oh, I'm so sorry you feel pain." Then they feel sorry for themselves. So you don't ignore them, but we don't ask the question. You don't ask, "Do you feel full?" Rather, you can look at the patient facial expression. "Hey, Joanna, I see you frown a little bit. What is happening? You ask them the open question. They might tell you, yeah, I have a little bit of discomfort. Oh, yes, that is not uncommon. I know that. I'll tell you, most of my patients tell me the same thing. It's a little bit discomfort at the beginning, but I guarantee you, you will get used to it. Don't worry. Or they might just say, oh, I started to have a headache, or I'm thinking about this illness. You know, they are going through a new process. They're grieving the loss of the kidney function. So do not put that question for them to answer. Just ask, what's going on? All right? So we can help them and empower them to be able to do the PD, accept the PD fluid, the amount, the increase intra-abdominal pressure, and being a PD nurse, they will get used to it. We have to support them. Okay, pain towards the end of the outflow and then goes away shortly after the inflow. Most of the time, that is called the suction pain. When I teach the patient, I say, well, if you have some fish tank or if you ever do some suction or using your straw to drink a cup of Coca-Cola or mango juice, whatever, right? At the end at the end of when the container is almost empty, you will hear the suction. So this is the suction from the PD catheter that is sitting against some abdominal organ, and then it can cause some suction pain. But once the fluid get infused back, the fluid is a cushion and push that catheter away from the intestine, then they wouldn't feel the pain. So in case that's the reason, if it is a CAPD manual exchange patient, easy. Just stop the drain. They don't have to suffer the pain. They do not have to drain every single 5-10 cc what is left behind. If they have discomfort, stop it and initiate the inflow. It's not going to hurt them if there's a little bit of fluid left. And then you might ask, Joanna, what is a little bit? 1 or 200 cc is fine. But if we're talking about a 1000 cc, that's another the thing. We're going to talk about the obstruction later. Okay? Pain at all time. It can be peritonitis. It can be some intra-abdominal issue that if it is all the time and we rule out peritonitis, then the physician needs to be involved. We might have to do some x-ray or further investigation. And again, we need to know the patient's recent bowel movement because being constipated and having excessive gas in the intestine can cause some discomfort and actually pain. Do we have any questions, Minahil?
Yeah, there is a question from Mr. Anjum that how do you manage the non-compliant patient?
Okay, non-compliant patient. We all have those. And hopefully, keep a finger crossed, is not the majority. But think about this. I'm going to share, again, I'm going to share with you my experience. We need to be able to establish good relationship with the patient, but yet keep our boundary. Okay. Try to understand why the patient is non-adherence. Here, we don't call it non-compliance. Nobody likes to be told you're non-compliant. It's a non-adherence. You're not adherent to your treatment care plan. So ask the patient, sit down. Never talk to the patient with the patient in a sitting position. You're standing, you're talking over them. That's the worst. Pull a chair, sit down with the patient at eye level with a calm voice. Chat with them a little bit. Hey, how are you doing? How is the family? Are you working or is there anything bothering you? I noticed that you don't do dialysis every day, but your prescription is that. And your phosphorus is high or your potassium is high, your blood pressure is high, and we really care about you. And I want to know, what can we do? Is there any problem, any barrier to stop you from doing all the dialysis? What can we do to help you? Sometimes it works, sometimes it doesn't. Sometimes it takes many visits like this. Have I done it many, many times to patients? Of course. I have, good thing is not a lot. I have two, three at a time. And then I just sit and talk to them and then ask them, can you do this for us? I don't want to say do it for me, then it become personal. But we say as a team because they are part of the healthcare team. They're part of the team member, right? Can you do this for us? Do the dialysis so you can be healthy? And then another trick that we have done is find out what is important to them. Okay. And if they, a lot of time is like my family, my children, my grandkids, well, do it for them because that is important to them. Okay. All right. My screen is shifting a little bit. I want to make sure you're still seeing my slide. Just a technical check. Yeah. Okay.
Yes.
And thank you. And then another story I want to share with you is my own story. My husband was diagnosed to have pulmonary fibrosis many years ago. And he was a nurse. I'm a nurse. And he was non-compliant. And the doctor told him to do certain things and he didn't do. I was really upset. Being a nurse, he's a nurse. Why are you not doing it? He looked at me eye to eye with a soft demeanor. He said, I just want to feel normal. That hit me really hard. If you think about it, these patients living with a condition, they have to modify the daily life so that they can live. Okay. Does everybody able to incorporate dialysis into the life and make it feel normal? Not everybody. So keep that in mind. And what can we do to help the patient feel normal? One of the physician told us another story, and the patient wasn't doing a lot of things, and the physician say, "What can I do to help you?" He say, "Can I just take a day off? I want to go sailing. I just want to be away from dialysis." And he has enough residual kidney functions. The physician say, "Sure, let's do it." He went sailing, he did what he wanted to do. He was a changed man. And then from then on, once a month, he got to be normal in his own definition, and he was happy. So work with the patient. I hope that helped you answer your questions.
Yes,
Okay,
thank you.
thank you. Next. So, and like I said, the inflow and outflow pain usually is at the beginning, but there's a lot of time they will go away after a while. And I have already talked about the triage, the troubleshooting, temperature, low pH, constipation. Make sure you have some bowel regimen protocol, or you establish a protocol with your physician if your clinic doesn't have one, so that you can triage that immediately. Okay, um, I'll tell you another thing. When I train nurses, I ask them to do like swearing, or, to keep a promise. I said, I want you to be very obsessive about patients' bowel movement in terms of frequency, consistency, um, quantity, and quality. Why do I say that? Frequency. I have one patient say, "Oh, my bowel movement is normal." I say, "So how is normal?" "Once a week." For a PD patient, we need to poop daily. We cannot have once a week bowel movement. Okay. And then the quality. If you don't know this, there's a chart called Bristol stool chart. it gives you the picture of different look of the poop. Then you can ask the patient, what is your poop look like? If it is all like bullet, the patient is constipated. Okay. The quality, the consistency, is it soft? Is it like rice soup, or is it like a cup of rice? Have some description. Ask them, because you'll be surprised what people interpret as normal bowel movement. And you have to be gentle to break the embarrassment of discussing bowel movement, and train them and talk to them in a way that they understand your knowledge about their bowel movement is a critical element on taking care of them. Okay, so don't be shy. And then the position of the catheter. Sometimes if the catheter is sitting in a center sensitive spot, if we give the patient full fill volume, adjust the body position, laying in bed, turn left, turn right, walk around. We might have to do it many times. Sometimes we can help to float the catheter in a different position that is less sensitive, and the pain will go away. I'm not just saying this from textbook. This is from clinical experience. Okay, so try it. All right, outflow pain with cycler. And that is another very common scenario, because PD cycler drained by hydraulic suction. And then the cycler is designed especially for the first drain to drain as much as possible. So patient can feel that suction. It is from the negative pressure adding from the catheter into the abdominal wall. So what can we do? Okay. No patient would like to wake up by a pain that they feel so uncomfortable 4 or 5 times a night, where however many cycles they have. It's very frustrating. Sometimes they say, I have to sit up and everything. So what can we do? First, again, make sure they are not constipated. Laxative, laxative, laxative. Call the doctor or have a protocol in place. The second one is if the cycler is too low, that can intensify the suction feeling. So maybe raise the position of the cycler machine. The third one is doing tidal PD. Tidal PD. And if I can ask some question, how many of you are familiar with tidal therapy when we use the cycler? Minahil, can you help me?
Yeah, we do know about tidal PD. We have read about it, but we are incorporating this feature in our APD machine in the upcoming software. So we do not have yet followed this PD, tidal PD.
Okay, so maybe we can do this a little bit deep dive in the next time. So basically, in short, is we can utilize the cycler and program it so that it does not drain the patient completely dry. We always have a little bit of volume staying behind to float the catheter so the patient does not experience that dry suction pain. Okay? Yeah, that's another therapy that we can discuss next time. And then the next thing is we can ask the interventional radiologist or the physician or the surgeon to reposition the catheter. But that usually we save to the last resort because it will be an invasive procedure for the patient. Okay. And then hopefully we don't have to switch the patient to in-center. Okay, obstruction. That's another very common complication. Patient call and say, my catheter is not working, my thing is not working. Scared. And as a nurse, sometimes we think, oh my God, it's mental rep. We think about the worst. Don't do that. Stay calm. Go step by step. We can work together. You and I, okay, we can work together to establish some work step by step questioning. Go from the simple steps and then escalate up to something that is more complicated, more complicated. Okay. So if a patient call and say, nurse, my catheter is not flowing, because that is scary for them. You say, oh, okay, I understand. So ask them, at what stage are you at during the procedure right now? You need to know, are they doing manual exchange? Are they doing a cycler machine? Have they been on cycler for a while? When did that happen, right? And most of the time is at the beginning when they first started the process. Okay, then you say, okay, let's walk through and make sure we don't have any close clamps. Now think about it. If you just say, do you have any close clamps? Do you have any kink? And because they are so nervous, right? They scan at it. No, no, I checked, I checked. So help them, walk them through and say, okay, let's do this together. Help me out here. And if they have FaceTime, you can do FaceTime. If not, make sure you articulate the steps in a calm and clear manner. Okay, walk through the mechanical obstruction check. Okay, let's start with your exit site. Can you tell me, can you feel your exit site? Do you have dressing? Will the dressing covering the catheter that might be kink? Take a look at it. Okay, no kink. All right, now let's trace the catheter all the way to the catheter clamp. Is it open or is it closed? Can you maneuver, pinch it a little bit? We give some pressure. Sometimes that can open up the pinching. All right. No, there's no kink, no clamp. All right, no worry. Let's keep going. So trace the whole system step by step, or ask them to actually feel it so that you can ensure what they are seeing. You can pretend, you can also visualize what they are seeing. You walk them through if there's any kink or close clamps. If the bag comes with some frangible, make sure they are broken. Okay, so a lot of time that can solve the problem. And then if that doesn't, you say, okay, there's no mechanical obstruction. Then we ask about fibrin. Do you see any fibrin? Or did you see any fibrin? Was there any fibrin the last exchange or the last few days? If there's fibrin, then we need to coach them. If you have the protocol to add IP heparin, then we ask them to add the IP heparin. But then also make sure the technique is correct. And usually the dosage is 500 to 1000 unit per liter of dialysis fluid. And then the next thing is ask about the bowel movement. Again, frequency, quantity, quality, consistency. And Dr. Abra, one of the nephrologists in here, say PD, peritoneal dialysis, stands for poop daily. We want to make sure the patient has daily poop. And Dr. Stephen Guest, he is a very well-known nephrologist, and he said, when I sat for his training, he said, well, I'm going to show you an x-ray. And then he showed us an x-ray. The x-ray bowels are distended, in other words, full of poop. Okay, he said, this is an x-ray from a patient that told us he has daily bowel movement and he is not constipated. So sometimes it can be an interpretation of your own bowel movement habits. So even though they say, yeah, I'm okay, try laxative. You'll be surprised. Okay. And then also we need to ask about the position of the bag, the position of the machine, if they are using any extension line. If the position of the bag is too low, they might not be able to fill. If the relevant position to the drain bag is not enough, they might not be able to drain. Or the machine position. I'll tell you a story. That was a funny story to me. The patient lives in a 2-story house. And for some reason, he got the idea to put like 3 or 4 extension line. The machine is on the second floor. He is on the downstairs at the kitchen. And then he told me the machine is alarming, it's not draining, it's not filling. Of course, it's too far away, right? So sometimes they will modify some technique that beyond our imagination. Okay, ask about extended dwell time. If the patient dwell for a long time, the fluid can be reabsorbed. Maybe that's why there's nothing draining out. And evaluate dry peritoneum. So this is another story. The patient called me and said, "Hey, Joanna, I'm not draining. It's very little coming out." I say, I check step by step, mechanical kink, obstruction, fibrin, bowel movement, your position in relevant to the manual bag, right? Everything step by step. And then I say, okay, tell me, did you do an exchange and what time did you do an exchange? Well, like our usual, about 5 hours ago. Okay, what is your drain volume? Huh, Joanna, interesting you ask. It was a lot. I filled 2,000. I drained 3,000 something. The bag was almost bursting. Okay, all right. So what can be happening is the patient did not close the drain line clamp and the fluid actually went from the fill bag to the drain bag. So not a whole lot had gone into him. So what can we do without bringing the patient home, especially those that might live far away? Ask the patient, okay, disconnect this system for right now. I want you to fill yourself with 200 cc and drain immediately and tell me what happened. You can stay on the phone. You can ask them to do it on their own. Depends on how smart the patient is, how reliable the historian they are. So by doing this action, we can ask them to do a quick flush to check the patency of the catheter. If it is patent, we're okay most of the time. Do we have any questions?
Yes, there's a question that how many members you train of one patient during the training?
How many members?
In one family, you train from patient family.
Oh, okay. Yeah, well, we I'm glad you asked. Sometimes we do have to set a limit, right? And depends on your size of the training room. If your room is very small, you might only accommodate 1 or 2, but the most maybe 4. It depends. And a lot of time we might have to put a little bit of flexibility. If the patient is an elderly patient or some patient that absolutely cannot take care of themselves, and require different family members to take turn to be involved to do the PD therapy, then I want to train all of them instead of I train one and then have that one train, because things, the information that get passed along might not be that accurate. So I would rather have all the people get trained at the same time instead of one training the other. But the size of the room is matters. Okay, if you don't have a big room, you don't want to cram a bunch of people and everybody looking over their shoulder. So it really depends. And I think I have done maybe 4 or 5 the most. And then you might want to set some um, ground rules. Okay, questions are okay, but if each one of them asking different questions and talking among each other and interrupting your training, then you need to be able to take control of that training session. Okay, I'm reading the question now. Um, when you conduct patient training, what do you do to focus during the training? Also, how many people? Okay. We focus on definitely the aseptic technique. Okay. That's the basic. Aseptic technique, what's the difference between sterile, clean, and dirty? How do they correctly perform the exchange procedure? Exit site care and how to prevent any infection and identify infection. Those are the basic must learn. And then the rest of them, the complication, we teach them. But knowing that if the complication doesn't happen, they most likely will forget about it. And then they need to call us. They need to call the PD nurse. In your cycler, you don't have a drain bag. How important is it to see the drain solution to pick the sign? Oh, it is very important. Okay. So can I ask, do you know what do they drain into? What kind of receptacle they have to drain the drain fluid when the patient is on cycler?
A drain bag and we have a drain line. So in the dual phase, the previous cycle drained volume get drained into the washroom or some kind of bucket. So at the end of the drain, patient can see the drain bag that how much fluid the clear is. So if the patient complains of drain pain, we ask them to do a manual exchange of 2 hours and then share a picture. So that's how we are managing it.
Perfect, perfect. So I like that idea. So we usually ask them to drain in a bucket, but make sure you teach them that drain line end will not be soaking in the drain fluid. The bucket is not sterile. As soon as you have some sugar contained effluent drain into the bucket, whatever is in the bucket, organisms can potentially travel back from the drain line because it's an open system back to the site to the patient. So make sure they have to tape it way above the level of the final drain volume. Number one. Number two, if they tape it to the toilet, make sure nobody is not soaking into the toilet water and nobody is using that toilet. You don't want to have any chance of contamination to that drain line end. Okay, thanks for the question. Okay. Okay, so inflow and outflow obstruction continue. What the nurses can do if the patient is in the clinic with us, the first thing is we adjust the patient position. Stand up, bend over, turn left and right in supine position, everything. Another interesting story. I'm training this elderly patient, okay, very nice man, and there was no problem with the catheter inflow outflow. And then one day he came, we feel, and then we did the training. And then when it's time to drain, nothing was draining out. Okay, as a nurse, oh my God, I hope it's not Aumento Rep. So I'm scared, but I say, okay, Frank, no worry. Let's do some troubleshooting. Let's change the position. So I put the feet up, he's reclined, turn left, turn right, nothing drained. Okay, let's try to stand up. So as soon as he was getting the movement from a sitting position to stand up, something happened. He passed some gas. And then guess what? The fluid come out from the drain line. And what I said is, good fart, Frank, good fart. So I know the distended bowel, even with gas, can cause some obstruction. So no gas, no constipation. Okay. So if it is fibrin, we want to add the heparin, 500 to 1,000 unit per liter. And if you are very experienced and if the catheter that patient has is compatible with the syringe, you can try to use a gentle pull and push motion to see if you can aspirate any fibrin. But keep in mind, don't do it too hard because you can actually break some capillary if the catheter is sitting next to an organ or some intestinal wall. And then the next thing you can also try is TPAIP. Okay, but usually when you have tried the first two, TPA doesn't less likely to work, but we can try it. If it is constipation, do laxative. Is the position of the bag, adjust the position of the bag, adjust the position of the cycler, and don't use a lot of fill line and drain line extension because it will take longer time for the patient to fill and drain and cut down the valuable, precious dwell time when the patient is getting dialysis. Or if the patient leave the solution in for too long and then they got a fluid absorption, we need to be able to manage the prescription and discuss with the patient so that we can prevent extremely long dwell time. And then if we try everything, nothing works, then call the doctor. Sometimes maybe a plain abdominal x-ray can identify the position of the catheter, maybe flip up underneath the liver or somewhere so we cannot drain. And then last resort, consult the surgeon. Is it omental rep? If it is, do we do omentopexy or omentectomy? Okay, hemoperitoneum. Oh, another scary thing that patient call and ask. So during training, in particular, young female that are still having menstrual period, we usually teach them, sometimes you might encounter some blood in the drain fluid. That might happen when you are having menstruating or ovulating. So at least give them some idea. But sometimes a man can have it too. So you will receive this phone call and say, "Oh my God, I'm bleeding, I'm bleeding." You say, "Okay, all right, where are you bleeding?" I see blood in my drain fluid. Okay, calm down, calm down. Okay, because a very small amount of blood, like 5 cc, can make the bag look like that red. Looks very scary. And we know 5 cc is not much. When we draw patient to get the lab work, sometimes we have to draw 10, 15 cc. So it's not that bad. So the first thing with hemoperitoneum, if you don't remember anything, first of all, reassurance. Don't worry, calm down. I'm here to help you. Okay? Let me ask you some questions. Let's go through it. Okay, do you have abdominal pain? Because we want to rule out peritonitis, right? And if they say, okay, I have pain. Okay, how long have you had this pain? And where is the pain? Because sometimes if the patient is having the menstrual period, they can have that abdominal cramp, right? So get more question and answer. Okay, on the pain level, on a scale of 1 to 10, 10 being the worst pain you can experience, how severe is the pain? That will help you to decide, do you want to bring the patient in to evaluate at the clinic, or the patient say is 10 out of 10? Maybe the patient need to go to the emergency room to see a doctor to get an evaluation. And then get a good description of the turbidity, the color of that bloodiness. Okay, and I see Binahil say you can take a picture. That would be great. If you have FaceTime, take picture, you can have a visual. If for some reason the patient doesn't have the technology, then you can say, does it look like Bloody Mary, Hawaiian Punch, or Kool-Aid? Now, those are like drinks in America, so you might have to find some equivalent or similar in Pakistan to say, is it look like whatsoever? Okay, but at least find some kind of description that the listener and the patient can relate to, so you can assess the severity of the bloodiness. And then ask the patient, hey, do you have any recent abdominal procedure or surgery? When was the last time you have menstrual cycle or ovulating? Is this the first time you have a bloody back like this? Do you have any trauma, or did you have you done any strenuous exercise? One of my patients allowed the grandson to jump on the tummy, and then they ending up having some bloody effluent. And then ask, are you taking any blood thinner? Okay, if a patient is taking a blood thinner, that might make it bloody too, because the patient is the blood is thin out, right? And then very importantly, assess for the presence of blood clots. If there is clots, what can happen? The clot, the blood clot can plug up the catheter. We don't want that. So then when there is clot, then we need to teach the patient to add heparin into the bag. Okay, so we talked about it. When the patient is still in the menstruating age, we want to ask them about the menstrual period, any signs of peritonitis. If they have signs and symptoms of peritonitis, we send the fluid for cell count and culture and then treat peritonitis. Any abdominal surgery, trauma, traction of the PD catheter, maybe they yank it, recent OBGYN colonoscopy procedure. And then now I want to talk a little bit about heparin. Okay, has anybody asked or think about heparin? Heparin is a blood thinner. If the patient is bleeding and we add heparin, is the patient going to bleed more? Anybody feel that way? Okay, don't worry. Heparin going into the peritoneum does not get absorbed into the systemic circulation. So it's only acting locally in the peritoneal space to dissolve those clots, to dissolve those fibrin, so that we can prevent the patient from clotting up the catheter. But if the patient is taking anticoagulant, then you might want to talk to the physician. Is it possible to reduce the dosage if needed? And there's another troubleshooting strategy is to use room temperature dialysate. Now, I don't know, in Pakistan, maybe room temperature is still pretty warm. The whole thing is we want to use some solution that is a little bit cooler. So you will feel cool to touch. What does that do? It helps vasoconstriction, and that might help to reduce the bleeding. So when a question came up, when do we have to start worry about it? Okay, if the bleeding, the bloodiness does not get any lesser, it's still very intense, very bloody looking, lasting for days, or the patient have pain associated with this hemoperitoneum, we'll have to worry about it. We might need to call the doctor to check a hemoglobin. What if this is a true blood loss that the patient hemoglobin drop? We need to triage that. Okay, so the normal scenario for hemoperitoneum is the bloodiness, the intensity of the color should go lighter and lighter. It might last 2, 3 days, 4 days, but each day it should go lighter. If it maintain for a long period of time, more than 4 or 5 days, and it's not getting any lighter with a lot of clots, patients starting to have discomfort, pain, that's the time we need to let the doctor say we need to do something. Of course, you have to call the doctor to notify the doctor anyway, but then if it doesn't get any better, even with cool dialysate flush, then you want to call the doctor. Okay? All right, so these are the breakdown of some of the possible reason for hemoperitoneum, which I already talked about. Okay, give you a quiz. Why adding IP heparin is not contraindicated when the patient is bleeding into the peritoneum, meaning we have hemoperitoneum. So if you want to put your answer on the chat, what do you think? Because it is an order by the physician. We have to do whatever the physician order. Because the complication of clotting the PD catheter is more severe than bleeding. Because heparin is not systemically absorbed from the peritoneal space. Because heparin will get absorbed into the bloodstream immediately. Option number 3. Yay! Very good. Yeah. Because heparin won't absorb into the systemic system. Okay, chylous peritoneum. Wow. Has anybody seen this white fluid? I have. Scared the heck out of me. I was so nervous. The first time I saw it, I didn't know what happened. I called the doctor right away. Well, no, first of all, I asked the patient, do you have any abdominal pain? No. And then a little bit of a background. The patient that I saw, she just had the catheter 1 week ago. Okay. And then I did the flush. I put in clear solution and came out just like that. I say, oh my God, what happened? I've never seen that before. And the patient didn't have any abdominal pain, no fever. So doesn't look like it's peritonitis, right? So I called the doctor. He ordered, send the fluid in for culture and sensitivity and cell count anyway, just to make sure it's not peritonitis. And then the patient has recent abdominal surgery, right? And the physician said it can be during the surgery, the physician nick a lymph node, and this is some lymphatic draining out. So we check for lipid, and it's a little bit higher in lipid, and we rule out tuberculosis peritonitis. And we check for malignancy. It's not malignancy. And it get resolved. It get resolved after about 6 weeks. So it continued to be like this for 6 weeks. And at some point in the middle, we even hold any flushing. We want to see if we don't use some fluid to aggravate it, is it going to be better? It didn't. Okay. But eventually it resolved. So it was okay. And when you see this, rule out peritonitis, call the physician, do all the tests to rule out peritonitis, and then observe. Okay? Cloudy effluent. I said it earlier, when the patient comes with cloudy effluent or call with hazy, we must rule out peritonitis. Ask them about, is there any abdominal pain and the location, the severity of the pain, the assessment of pain from a scale of 1 to 10. How painful are you? Do you have any fever? Call the physician. Now, I don't know in Pakistan or in your practice, do you allow the patient have period of dry peritoneum? Yes or no?
Yes, we do sometimes.
Okay, so if the patient has thank you for the answer. If the patient has dry peritoneum, ISPD guideline is we need to fill the patient with at least 1000 cc, 1 liter of fluid, and dwell for 2 hours before we collect the fluid to send in for culture sensitivity and cell count. Because fluid coming out from a dry peritoneum does not give us a very accurate result. And dry peritoneum defined by anything less than 1 liter. However, If you have no choice, that's the only thing that you can send in. If the cell count is more than 100 cubic millimeter, then you must look at the differential. We can only get a positive diagnosis of peritonitis when the polymorphonuclear cells or the neutrophil is greater than 50% among those white blood cells in the fluid. But best practice is have at least 1 liter and dwell for at least 2 hours. And then whenever we see cloudy effluent, immediately initiate the treatment for peritonitis and then adjust the treatment when the lab result comes back. I got a good question here. Was I able to achieve any clearance during the 6 weeks with the patient that have chylous fluid, right? Um, Actually, because the patient was a transplant reject and she still have enough residual kidney function that she did not have to do any dialysis. So we were only doing weekly flush, but then every flush yield the same whitish color. We rested for about 2 weeks and then we flush again and it's still the same. So in the end, the physician say, well, her chemistry her residual kidney function has dropped. We need to start dialysis. So we did start dialysis and that milky white fluid lasted for another about 10 days. And then it went away. So that's just my clinical one single case experience for me. But like I said, it's not very common, thank God. And we just have to do the test, make sure we rule out peritonitis and check for cell count, check for lipid, and then check for patient's albumin, because when they have that kind of um, chylous fluid coming out, they lose a lot of albumin. They lose a lot of protein. We want to make sure we monitor the albumin and encourage more protein intake. Okay, next one is the complication due to increased intra-abdominal pressure. It can be hernia, it can be leak, scrotal swelling, hydrothorax, or shortness of breath. And I show you a picture of different position that a hernia can happen. Okay. Okay, hernia. So when do we see the presence of hernia? It can be observed when we do a monthly visit with the patient, or the patient might call us and say, hey, something is sticking out. Now, another thing that I want to ask you to do is a very good practice. When we check the patient's exit site, do not just expose that little area to look at the exit site itself. Make sure you practice shirt up and lower the pants so you can see the entire abdominal area. Why is that? So we can see if there's any hernia. Okay, remember, hernia is not just umbilical. It can be epigastric, inguinal, or femoral. So if you ask the patient to pull up the shirt, lower the pants, you can see the entire abdominal area. So then you assess when you see a hernia, you want to assess the severity and do some pain assessment. Gently push it and see if it is reducible. Okay. And knowing that there are different locations, as I demonstrated to you in the previous picture, and then every visit, we need to assess how fast is it growing or is it stable. We teach the patient, okay, you need to observe this hernia on a daily basis. If it is getting any bigger, if you have pain, discomfort, call us right away. For umbilical hernia, there's a risk of strangulated hernia. So that is an indication we need to have emergency surgery. So we have to teach the patient to report whatever is happening at home. Okay, and the next slide, I'm going to talk about this. So the intra-abdominal pressure, what can impact and make the hernia worsen? Increased field volume, okay, or the position of the patient. The least amount of intra-abdominal pressure is lying down and then standing and sitting. Surprise, huh? Standing actually has less intra-abdominal pressure than sitting. And then coughing and lifting, straining when they do a bowel movement or strenuous exercise. So the intra-abdominal pressure when the patient has 1 liter in a sitting position is the same as a 3 liter um, field volume when the patient is in supine position. What does that tell me? If the patient has hernia, we need to focus most of the dialysis when they are in supine position. If the patient has residual kidney function that is enough, we might be able to do just the cycler dialysis and maximize the field volume and then dry when they are walking around. But keep in mind that will pose some challenge. Will the patient be getting enough dialysis? How is the adequacy? Is the patient getting enough ultrafiltration? If the leak is so severe that we have UF challenge, then we need to think about surgery approach. And sometimes patient might already have a hernia before they start PD. So if the surgeon can do an evaluation, and I have seen nephrologists did the evaluation themselves too, and before the surgery, so they can do the hernia repair and the placement of the catheter in the same surgery. So what can a nurse do when the patient presents with this hernia? Depends on the severity. If it is very severe or if you cannot assess the severity because the patient call you ask the patient to drain the peritoneum dry and come for the assessment. If the patient is on manual exchanges, we might have to change the patient to CCPD with night field volume and dry day. And then definitely observe the size of the hernia and then ask the patient or yourself to report when the size of the hernia is getting bigger and or if the patient experience pain or if it is not reducible. Definitely report if they are coughing or if they have constipation. Why is that? Because coughing and constipation create the highest intra-abdominal pressure. So I have taken care of patients with umbilical hernia, pretty stable, but I teach them anytime you have a cough, no matter it's a cold or allergy, let me know. We need to treat your cough. And I ask them to use a little pillow to support the place where the hernia is when they cough so that it's not pushing the hernia out and aggravate the hernia situation. And I make sure they are not constipated so they don't have to strain, increase, and have that Valsalva action to have a bowel movement. Those are extremely important for us nurses to know and for the patient to know so they can report as needed. Okay, so if the patient has residual kidney function, we can probably do low volume supine dialysis. But if the patient does not have any urine output, is anuric, and they are very likely to have overload, we might have to switch the patient to temporary to hemodialysis and then do surgical repair. Now, keep in mind, help the patient, be the advocate. If the patient is going in for a surgical repair, talk to the surgeon or talk to your nephrologist, whatever your practice pattern is. Make sure that they put a mesh wire, because if they don't, the chance of recurrence is very high. Okay, and ISPD has a paper to teach us, to guide us how to slowly increase the field volume after the patient has been on hernia repair surgery. And the protocol is rest with no dialysis for 1 or 2 days if the patient has enough residual kidney function, and then slowly increase the field volume from 500 to 1000, and for how long. And all of those are in supine, and then later on increase the field volume to, if as needed, if they need to have field volume when they are ambulatory. And I see some questions. Were you able to achieve? No, okay. Okay, the question I think is about chylous peritoneum. If the condition persists with the chylous peritoneum, do we switch the patient to hemodialysis? We really need to find out what is the underlying cause of that chylous hemoperitoneum. Sometimes an interventional radiologist might be able to go in and fix that lymphatic leak if it is so. So before we switch, we might want to see and identify where the leak coming from. What's the cause of that whitish fluid? So recurrent peritonitis should recurrent peritonitis switch to HD? No. Recurrent peritonitis by definition is having the same organism after 4 weeks of completion of peritonitis with the same organism. The one that are indicated to switch to or consider to switch to HD is relapse and refractory. Relapse is defined as the same organism, another episode of peritonitis with the same organism within 4 weeks of completion of peritonitis. Okay, so what that means, what that tells us is we have treated the patient with the appropriate antibiotics and complete the course. But then within 4 weeks' time, the same organism has come back, meaning there is something inside. It might be a biofilm that the antibiotic that we gave the patient is not able to eradicate the peritonitis. So we can try to treat the patient again, but the likeliness of getting rid of the infection is small because it's relapsing peritonitis. Then we might have to consider pulling the catheter, switch the patient to hemodialysis, rest for a month or two, and then reconsider PD therapy. Refractory is the patient is on the right therapy according to the culture and sensitivity, okay, for 5 days, and there's no improvement. You can do a cell count and the cell count is not going down at all, and the patient continues to experience abdominal pain. So that means even though according to culture sensitivity result, we're treating the patient with the right antibiotics and the patient is not getting any better, that's the time we need to think about removal of the catheter. And then one more is called catheter-related peritonitis. If the patient is having an exit site infection and a peritonitis with the same organism, that is a risk because the likeliness of the organism actually originate from the exit site, travel through the tunnel and into the peritoneum. That's why the organism is the same. and then leading to peritonitis. So we are actually having a more severe infection that we have to treat. Then we need to think about removal of the catheter, switch the patient to temporary hemo, and then bring the patient back possibly later. Is the truss ever in? Um, Franklin, I'm sorry, I'm not 100% sure what you mean by is the truss ever indicated for a PD patient with a hernia? Do you want to unmute yourself, please,
Yes,
Frank?
certainly. A truss is a belt that applies pressure to a hernia to prevent
Oh,
it,
okay.
to hold it in.
Yes, yes. I have used those before. I didn't know that that's what it's called. Thank you so much, Franklin. And I have a patient with bilateral inguinal hernia. Okay. I did it. He was using it for a while, but then because of the increased intra-abdominal pressure due to the field volume, eventually he still have to have surgical repair. But yeah, definitely, I think that might help. Hmm.
Yeah, I was only thinking of it as a temporary mitigation.
Yes, yes. Yeah, and then it might help to provide some support and comfort for the patient too. But great idea. Thank you.
You're welcome.
Okay, leak. It can be external, it can be internal. External is usually happen at the catheter exit site. What can you see? You can see some wetness at the exit site. Now, I know that some practices, some clinician will get a glucose test strip, stick it at the exit site and see if they change from yellow to green. Oh, green is dextrose. Please don't do that. Why do I say that? Think about it. If this is truly a leak from the peritoneum through the tunnel to the exit site, the glucose solution, that means things can come out, germ, bacteria, microorganisms can go in. The glucose test strip is never sterile. If you stick something there, we can potentially cause an exit site infection or even peritonitis. So if the patient leak is enough, if you can get a blunt syringe, the one without the needle, and aspirate just a tiny bit and put it in a glucometer. And if you see high, you know pretty much that's a leak. If that's the case, we must use sterile dressing. Okay, like I say, we don't want any bacteria or any contamination that can happen. Drain the peritoneum to stop the leak, and then hold PD. Give me a second. My apology. So hold the PD. Allow time for the patient to heal. If the patient has enough residual kidney function, we might not need to change the patient to backup hemodialysis. But if the patient doesn't, they might need to do hemo. Okay. And then what about internal or subcutaneous leak? They can be at different area. It can be around the exit site. It can be on the abdominal wall. If the patient is more like sitting all the time, bedridden, it can be on the sacral area and any depending area. So what you can see when you do the shirt up, lower pants, you might see some edema on the abdominal wall like what I show you on the picture, okay? Or you can see the orange peel skin appearance. Because of the edema, the skin got stretched. Then the pore is more obvious. Then you can see it's almost like an orange skin appearance. Okay, when you gently push it down, it's pitting edema. You know, oops, we are having some subcutaneous leak. What other signs and symptoms? The patient's drain volume will be decreased. We can see pitting edema and orange peel appearance, or sometimes genital or abdominal wall edema. Sometimes patient might even have, scrotal swelling. I have seen a patient with labia majora swelling. It's scary. It's scary. Again, we have to reassure them. Make your assessment. If it is really affecting the drain volume, is the leak is not resolving by holding the therapy, they might need to do some more examination, find out the leak, and then do repair if necessary or if they can do it. Okay, so when the leak is so severe that it's affecting ultrafiltration and it's not resolving, even you do low volume supine dialysis, then we call the doctor. What the doctor can do is make an arrangement for the patient to do this diagnostic test. This one is to do a CT scan. They will add 100 ml of iodinated contrast to the PT dialysate bag, infuse it, let the patient stand or walk around for 1 hour, and then do an abdominal CT scan. Then the image on the left is you can see the subcutaneous leak. The image on the right is doing it using MRI. Now, keep in mind, MRI is a little bit more expensive, but the dialysis solution itself can be like a contrast. So it will show on the MRI image. They don't have to have the injection of the contrast dye, but for CT scan, we need to. And one of my experiences, one physician, patient experienced this leak and is severe enough to have fluid overload and is very edematous around the abdominal and sacral area. So what the physician did was he held the PD for 2 weeks and then arranged a CT scan. By the time the 2 weeks, when we did the CT scan, we could not find any leak because during that 2 weeks of resting period, the leak has healed up. So if you want to do an imaging like this, do it when it is leaking. Okay, I'm going to read this comment from Franklin. This is not a question, but something that is obvious to many of us regarding tidal therapy. In addition to keeping the patient wet, it also maintains high clearance rate by preventing the dextrose concentration from decreasing too low during dwell. Yeah, and I agree with you. Besides the clearance is actually very good for ultrafiltration. So if we want to discuss about this topic, maybe I'll move it to later. Okay? All right. But thank you for your comment. I love it. Hydrothorax. Okay. So what happened is the patient complained of shortness of breath. And you can see the ultrafiltration has decreased. And then you can see the lung sounds are different. So I want to urge all the nurses, when we take care of a new patient in particular, make sure you do a baseline lung sound because any kind of change once we start PD can mean something. It can be that simply the patient maybe is absorbing the fluid or not getting good ultrafiltration, but it can also be a congenital defect. There is a communication, there is a fistula between the peritoneum to the pleural cavity, to the pleural space, and then the dialysis fluid has gone up to the pleural space and hindering the respiration. The patient has really bad shortness of breath. Okay, so when we have a baseline, we can easily identify changes. And this kind of complication usually happen on the right side. It's very rare, thank God. So if you think that might be the situation, call the doctor. So the doctor can do a chest x-ray or they will do thoracocentesis drain out those dextrose fluids so that the patient can breathe better. Okay. And if we do a test, those glucose concentration usually is higher because it's dialysis solution. However, if we leave it in for a long time before we test it, the glucose can absorb into the systemic system. We might not be able to detect the big difference. What is the treatment? Yeah, 50% of the cases, patient might be able to stay on PD, but they have to go through a pretty painful process. And I'm going to show you some slide later. Okay, so the surgeon can do fluorocentesis and inject some talc or tetracycline to sclerose that leak, to basically make it hard. So stop the leak, and the patient can temporarily move to hemodialysis during that healing period and then put the patient back on PD after it's completely healed. Keep in mind, a very detailed conversation need to happen between nurse, physician, and patient. They have to have a strong desire to stay on PD because this procedure is very, very painful. The pain doesn't just happen during the procedure, even it linger for a few weeks. Okay, and it's not 100% successful. Um, I have more slide to talk about the hydrothorax later, but this one I want to show you. Have you ever seen anything like this? We have a few times. This is not an exit site infection. It's contact dermatitis. The patient came to us, we look at it, there's no pus drainage, but you can tell the skin is burned, is very irritated. But if we see this, we need to see us first assess for um, peritonitis. No, I'm sorry, exit site infection. Okay, see if there's any pus drainage and any swelling. We can see some swelling and any presence of pain or itchiness. And how long have they have that? Do they have any trauma? Now, the critical part is ask them how do they clean the exit site in every single step and detail. From the time they take the dressing off or they didn't take the dressing off, do they tape the catheter so that it's not dangling and traumatizing the exit site when they take a shower? What kind of water do they use when they take a shower, when they care for the exit site? What kind of cleansing agent do they use? Do they apply any topical prescription? How do they dry the skin or do they dry it? What kind of dressing do they use? And because of patient privacy issue, we need to obtain a consent from the patient to take a picture. Okay, with this particular patient, he was using, I think it's neosporin ointment. Okay, and he has developed those allergic reaction. Think about a lot of people, they are allergic to neosporin, and the ointment create a moisture around the exit site, doesn't allow the exit site to dry, right? So that's why it is like this. And also, the patient had over applied the neosporin ointment, so it became this extended area. Okay, I don't see any question. All right. So this is a picture of a cuff protrusion. It's an external cuff protruding to outside the exit site. You can see this a little bit of silicone looking, and then this is the Dacron cuff. So if the cuff is protruding, it causes a lot of irritation. It can cause redness. It can lead to exit site infection. So how do we care for that? We need to teach the patient very meticulous exit site care and also report if there's any pus drainage, the swelling is bigger or more painful. because it can cause exit site infection or even chronic exit site infection. That is, the exit site infection lasted more than 4 weeks. But the surgeon can actually do a salvage procedure by externalizing the cuff and shave it. But that is only if this catheter is a double cuff catheter. If it is a single cuff, we cannot do it. If we pull it out, we need to put a brand new one in. Okay, catheter.
Excuse me, Joanna. Sorry for
Yes.
interruption. Can I remind you that we are already past 15 minutes of our time and it's already 11:45 p.m. in Pakistan. So can we finish it in next 10 minutes? And
Oh,
can,
okay. Okay. I
yeah,
thought we have another 15 minutes. Okay. Yes. Was
yeah,
it
yeah.
two
Thank
hours
you.
or is it 2 hours or
Uh,
one hour?
eh, it was 1 hour and 30 minutes, and we are already 15 minutes ahead of time, but it's okay. We can finish it up in next 10 minutes.
I'm sorry. I thought it was two
No, no,
hours.
it's
My
absolutely fine.
apology.
It's absolutely fine. No, no, it's absolutely fine. We are really enjoying it. We also don't want to wrap it up, but this is the way we have to.
Okay. Thank you. So this will
You're
be my last one.
I
This will be
think
my
I
last.
think I think we can go ahead. This is very informative stuff,
abs
and I think you can finish your slides the way you have planned it. Dr. Roshina, we can like wait.
sure, sure, sure,
Yeah,
sure.
let's
If
not wrap it up
okay,
and let Joanna finish it properly.
Okay. I'll speak a little bit faster.
No, no,
Okay.
no. Take your
Cath
time. This is
catheter break. Can I ask, do you have the capability? Do you have this repair kit where you practice? Minahil. It's called a catheter peripatch repair
No,
kit.
no,
Huh?
ma'am.
No.
No, I
Okay.
think what the way it works probably is we don't repair the catheters at Bionics or Bionics team. It goes to a surgeon who manages this catheter. But this is something we can learn and see, and Dr. Numan can decide should we get into this or we train our surgeons to get into this space.
Yes, this is a great way. So I can be in touch with you and show you what this is. So if a catheter is cut very close to the exit site, we can do this repair procedure so that the patient doesn't have to go through another surgery. Okay, so we'll talk about it next time. Okay, some interesting. I
But
hope
it's
it's interesting.
absolutely great to know that there's an option to salvage the catheter.
Yeah.
Absolutely.
So what is the purpose of adding sodium bicarb into the dialysate? I'll go it fast. Okay, because sodium bicarbonate can neutralize the low pH PD solution, then reduce the abdominal pain. Constipation is common among PD patients. What complication can constipation cause? Outflow obstructions and peritonitis. I didn't talk about it because this is a non-infectious complication, but if the patient has chronic constipation, they are at a higher risk of peritonitis because it can cause intramural migration of the microorganism. So make sure your patient is not constipated. Which one is the treatment of hemoperitoneum? Use room temperature dialysate to perform exchange or flush so that we can promote vasoconstriction. And a lot of this information came from ISPD guideline. So this is an image of a plain X-ray that you can see the location of the PD catheter. So in case there's a flow obstruction, this nephrologist can identify that from the plain X-ray. And the normal position should be deep in the pelvis, not too deep, but right around here. Because when it is too deep, then they can have pelvic pain, they can have bladder pain or rectum pain. Okay, so this is a picture of a cartoon for the omental wrap. So if this is where the catheter is, it's in the deep pelvis like it should be, but then the omentum wrap around it. So when we do inflow, because of the pressure of the fluid, we can feel the patient with no problem. We are pushing the omentum away from the catheter. But as soon as we try to drain, that suction from the catheter in order to drain suck that omentum around the catheter holes so we wouldn't be able to drain the patient. But that's the mechanism of what happened when omental wrap. And this is another picture of the catheter wrapping around the omentum. Milky white, and we talked about it, rural peritonitis. Make sure there's no trauma. Do CT scan to see if there's any malignancy, and it says low-fat diet, because sometimes if the triglyceride is up, it can also cause the milky white fluid. And we talked about it, send the fluid for triglyceride. Hernia, we talked about it already. So this is something that the doctor that did the presentation with me um, he used the peritoneal neography, confirm the leak, and then do pleurodesis to inject, I think it's on the next slide, pleurodesis to inject TEL, doxycycline to seal, to sclerose that area. But then he keep the chest tube open to make sure that any fluid accumulate in the pleural space will get dry. Cuff protrusion, we talked about it already, and cycler alarm. So cycler alarm is very annoying, and one thing that I want to talk about is in case the patient has a lot of cycler alarm, I would like to ask you to bring the patient into the clinic, do manual exchange. Do it in 2 different positions, one in sitting and one in a lying position, or whatever way they do the cycler. Because if the flow rate is very different when they are sitting versus when they are lying down using the cycler, you might want to have a conversation with the patient. Seems like your catheter is in a position that works better when you're sitting. Do you want to switch to CAPD, or is there any way you can do a daytime cycler? So modify the method how we do the dialysis. Otherwise, we might have to do reposition the PD catheter, which is a abrasive surgical procedure. Okay, so I think I'm going to stop right here. Thank you.
Uh, Thank you so much. So with that, we are concluding our session. Any questions we can check for? No, I think there are no.
We do have one question pending that
Yeah.
if patient is not following the prescribed prescription from his primary nephrologist and is following self medications from the chat GPT or Google, then how should we manage that patient?
Oh, this is a very challenging case. I'm not 100% this is a good forum to discuss. I would like to invite nephrologists to chime in. And as a nurse, if I'm aware of these kind of remedy that the patient go with, I will talk with the nephrologist and have a care team meeting. And then again, we want to understand why the patient choose to do that versus following the nephrologist prescription order. Is it trust? Is it just some you know pre education from culture whatsoever? I would say ask the patient, understand why they do that, and then have a better discussion. I think once you know the why, there might be something that we cannot change. But if it is something that we can have a discussion and persuade the patient otherwise, at least we can try it.
And
Thank
one
you.
other thing I would like to add is it's amazing to learn that you characterize sitting positions versus lying down. This is the first time I heard in my life. And I think that could be a huge tool for especially for patients which have drain issues, and then drain
Yeah.
alarms leads to a lot of night disturbance. I think
Yes.
we would love to follow up with you on that. I want to even have a standardized protocol at Bionics where when we install the catheter, we evaluate at the beginning, okay, you sit down, what is the drain time? You lie down, what is the drain time? And we record that. And maybe every 6 months, and then if some catheter is moving or what else is going, we have a baseline, and then we expect, oh, this patient will have drain issues or drain pains or these things versus some other. We right now, I don't think so. I've heard any clinic who characterizes the drain behavior proactively. So that, and I think that's amazingly useful learning apart from a lot of learnings that I learned again so many times in today's session.
Yeah, well, this is from, years of experience taking care of patient, trying to troubleshoot, and you learn tricks and here and there, and I love to share.
So, Ms. Manahil, do we have any other questions?
No, please.
Uh, okay, so with that, we came to end of today's session. And thank you so much, Ms. Joanna. It was wonderful hearing you. I'm sure everybody is so inspired right now, so much motivated, learned a lot, and it was wonderful. And I'm grateful on behalf of Team Bionics for your time. And thank you, everybody who joined us. Have a wonderful weekend ahead. Thank you. Good night.
Thank
I
you.
was I would also say thank you to you on such a short notice. You gave us the time, and we learned amazing things from you. And I'm hoping this is just the beginning, and we will learn a lot from you going forward.
Okay. And one thing that I want to encourage you to do is I remember you talk about on call. So if you just put in some algorithm, patient say obstruction, first thing what you do, and then all the nurses have like a checklist. So you can do step by step instead of scrambling to think about what should I ask. That can be a good tool to develop. And I can help if you want me to.
That is
Okay.
something we definitely need. We need a systematic approach to sort patient issues out, which is consistent across the multiple nurses, multiple technicians, multiple facilities, like a flow chart or what is the system method to the madness. Absolutely. Would love to work with you on that offline.
Yeah. Well, thank you so much for staying so late, staying up so late and listen to this presentation. I hope this is helpful. See you next time.
Absolutely.
Thank
Sure.
you.
Thank you. Thank you so much. Good
Thank
night.
you.
Good night.
Thank you, Joanna.
Thank you too.
Thank you.
Bye-bye.
Bye-bye.
Thank you.